someone called Farjun. Who's Farjun? Hang on, we haven't actually. Have we started, David?
Oh, sorry. I thought you wanted me to start.
Okay, we've started. Right. Good evening, everyone. I'm Ben Coleman. I'm the Deputy Leader of the Council and Cabinet Member for Health and Social Care. And welcome to the...
Just disappeared, Ben.
Yeah. Oh.
Ben, that was very impressive.
As I was saying before I so rudely interrupted myself, sorry about that. I'm Ben Coleman. I'm the Chair of the Health and Wellbeing Board. Welcome all of those of you to the meeting today and anyone who's watching online. I'm just going to go around quickly so that people who are in the room and also whichever virtual room they're in know who's with us. So if I just call names out as I see them on screen, please. We've got a mixture of people who are members of the committee and people who are residents joining us to contribute as well. Jim.
I'm Jim Greeley. I'm the chair of HAPSON, Hammersmith Fulham Save Our NHS.
Thank you.
Thanks.
Thank you very much. Peggy.
Hi, I'm Peggy Coles. I founded the Hammersmith and Fulham Dementia Action Alliance.
Wonderful. Welcome. Pleasure to have you here. Patricia. You're on mute.
Sorry, Ben. Good evening. Councillor Patricia Quigley. I'm the lead member for Inclusive Community Engagement and Co-Production.
Thank you very much. Thanks for being here. Jackie.
Good evening, Councillor and colleagues and partners. Jackie McShann, Strategic Director for Children's Services. And Councillor, my internet's a bit wobbly, so if I turn my camera off, it's just so that I can stay at the meeting. Thank you.
No problems. Thank you. Thank you for coming. Linda.
Hi, I'm Linda Jackson. I'm the Director of Social Care for Hammersmith and Fulham.
Welcome. Sue, I should say.
Hi, I'm Sue Spiller, Chief Executive of SOBUS, the local infrastructure provider for the voluntary sector.
Brilliant. Thank you. Welcome. Joe. Joe Beatty.
I was struggling to unmute there. Hi, Councillor. Hi, everyone. I'm Jo Beatty. I'm the Assistant Director for Specialist Support and Independent Living in Adult Social Care.
In the Council. Great. Thank you. Nicola.
Nikki Lamb, Director of Public Health, Hammersmith and Fulham. Sorry.
No, my apologies. There are two Nicholas. I wasn't clear. Thank you, Nicola. Nicola Kay.
Hi, sorry, yeah, there's too many of us. It's Nicola Kay, the Director of Population Health and Reducing Inequalities, working across North West London System, working for the Integrated Care Board.
So you work for the NHS?
Yes.
I'm just thinking we're just a lot of not everybody's aware of all the time. Brilliant. Thank you so much for being here. And June. Just down there as Farjan, but just
yeah, that's me. Yeah, how did I know the mute wasn't going to work? Good evening, Councillor Coleman team. June Farquharson, Assistant Director for Population Health and Health Inequalities for the NHS.
Brilliant. Thank you also for coming. Lucy. Lucy.
Hello. Yes, I'm Lucy Richardson. I'm a councillor. Hello.
Good. Your connection's a bit wobbly, just to let you know. Meryl.
Hi, I'm Meryl Hammer, a resident of Hammersmith and Fulham, the Secretary of Hammersmith and Fulham Save Our NHS.
Marvellous. Thank you very much. Thanks for coming. Suhana.
Evening, everyone. My name is Suhana Ahmed. I'm the Clinical Director for Older People's Mental Health Services in West London NHS Trust.
Excellent. Excellent. Very good to have you here. Thank you. Toby.
Hi, Toby Hyde, here in my capacity as chair of the Dementia Partnership Board for Hammersmith Fulham.
And also wearing lots of NHS hats?
Yes, a couple.
All right. I won't probe that at this moment. Thank you, Toby. Thanks very much for coming. Nadia.
Good evening, everyone. Nadia Taylor, representing Healthwatch today. I'm a local resident and also chair of Carers Network, so I bring the perspective from carers as well, and chair the local carers forum in Hammersmith and Fulham.
Very helpful. Thank you, Nadia. And I've got Helen Mayan. Helen, I don't know if you're with us.
Sorry, I can't get off mute. Helen Mangan, Deputy Director at West London NHS Trust.
Great. Thank you very much. Thanks for coming. And Jacqueline?
Hi, good evening. I'm Jacqueline Daly. I'm a councillor for Addison Ward.
Wonderful. Thank you for being with us. And you also chair the housing committee, is that right?
Yeah, housing and homelessness.
No, thank you. And I've got just one more name, and I'm going to, because it's a long, it says Divya Venkat. But can you tell me what I should have said?
Yeah, so it's perfect, Ben. Hi, hello everyone. I'm Divya Venkat. I am here as the chair of Dementia Action Alliance.
Wonderful. Well, welcome. I don't think we've had the pleasure of meeting properly. Thank you so much for doing that.
Pleasure.
Yeah, it's great. Great. Well, we're here today to talk about dementia. We're here today to talk about inequality. And we need to just start, if I may, answer. I'm going to be looking from you as another screen as well, just to put stuff on two screens. But let's just start by checking if we have any apologies for absence, formal bits. David? Any apologies?
Sorry, apologies from Lisa Redfern, Sue Rooston, and Philippa Johnson.
Okay, thank you very much. Any declarations of interest? Okay, good. And you're allowed to say we're all very interested. That's a good declaration. And then we have minutes and actions of the last meeting, which you may have had a chance to look at. The main, we talked about a number of things. We had Sue Rooston, who's not with us, agreed to look at winter pressure communications to encourage vaccination take-up rates. She's not here, so can't ask her to report on that. We talked about the hospital discharge fund, and we agreed that there would be an end-of-year report outlining the outcomes of the various schemes around that, so and the difference they've made. So, well, that is now. Can I just check? We're talking about an end-of-year report. We are almost at the end of the year, aren't we? In a week's time. So I guess we'll be bringing that report to the next Health and Wellbeing Board. Is that right, Linda?
Yes, that's great. Thanks, Councillor Coleman. Yeah.
Good. Okay. So it's important, yeah, looking both at the that what we've done and the programs, but also the difference that they've made. Yeah. I think it's going to be really interesting. Good. Okay. Then we looked at the integrated care system and the healthcare partnership. The integrated care system being for the 8 boroughs, the health and care partnership being Hammersmith and Fulham's part of that, and the actions were that, I don't know if anyone knows if this has happened, Sue Rooston from the NHS was going to arrange a meeting with HAFSON and the Trish Longden to further discuss resident engagement with the Health and Care Partnership. Meryl, you're on mute. It's one of those evenings.
Sorry, I can actually answer that. We did meet with Sue Rooston, Trish Longden and Philippa. I'm not sure that as yet anything definitive has come from that in terms of both responsiveness and accountability to Fulham and Hammersmith residents. So it may be something that HAFSON needs to follow up. Then I had another question about the earlier item about the hospital discharge.
Sorry, sure.
Is now the time to ask it?
Yes.
So it's really to ask, what's the North West London position on discharge to assess? And
oh, I see.
You may not have the answer.
No, I'm going to have to ask you to, just because we've got a lot to get through this evening. It isn't particularly under that item. That's more about just. But the North. Oh well, all right. The North West London position on discharge to assess. We'll do it quickly. Is Linda? Correct me if I'm wrong, but we are. Well, Linda, you set it out. I'm not going to have you correct me if I'm wrong. Why don't you just set out the position?
Yeah, so we're no longer doing discharge to assess across North West London. That was something that we did throughout COVID, and we stood down our regulatory requirements of the Care Act, enabled us to do that. However, what we are doing, we're using the monies that we've been given to further improve our discharge, both in capacity and process as well. So that's why the report that will come back in a couple of months' time to this board will be of interest to you, Meryl. If you want to have a specific conversation about discharge to assess, I'm more than happy to do that outside of here.
That would be very helpful. It's just that
sure,
in a different ICS, a really bad experience. So it's
Well, we think, yeah, we had it. Well, to be honest, they stopped giving us the money for discharge to assess. They expected us to carry on doing it without the funding. It's a lot more expensive, and also we weren't sure that it was the safest way of discharging people, not assessing them until they were out of hospital, and because the doctors and the nurses get really worried that if they're discharged before they've been properly assessed, they have to have a huge packet of care, which may be more than what people need, costs us more, which is you, the residents, more. And then if we have to remove that care, some of it because people get worried. So it creates worry, and it's not the safest way of doing things. And the funding was withdrawn. So Linda and her team came up with a better way of doing things, which we'll explore in the report next time.
I look forward to that report. It's also the issue of readmissions, but thank you.
That's all related, absolutely. Good.
Chair, if I may, can I just say I will take an action to pick up with Sue Rooston and the Health and Care Partnership exec about resident engagement.
Thank you. That's great. That's a nice pickup from what Meryl said. Thank you very much. Yeah, and we had a very good health and care partnership discussion locally with people and residents. And was that the launch event? Are we going to do a more visible launch event still aimed at residents, Linda?
Yes.
We are still okay. Well, we ought to talk about that. So it's really meaningful, because a lot of these things can feel very jargony. So it needs to be something which is really, people understand what it's about and how it actually will improve their health and how they can get involved in a way which is perhaps more approachable than sometimes these things are.
Yeah.
Good. Okie dokie. So if you're all happy with that, there's no more minutes arising, and no corrections to the minutes. So we'll accept those. We'll accept those. Good. And that brings us on to then the. Sorry, I'm just going out to the thing here. Yeah, and that brings us on to talking about reducing inequalities. And June, I think you're going to lead about this. And just before you do the presentation, if you can just sort of set the scene of what this presentation is going to be about, the context of it.
So Nicola's going to start it, Councillor Common.
Nicola's going to start it. Okay, but you're going to talk about what you've been doing, what you're aiming to, what the North West London Integrated Care System, the 8 councils working together, is going to try to do to reduce inequalities.
Yes, that's right. Yeah.
Well, over to you then.
Yeah, what we've set out, and we pulled together a few slides. I'm not sure if people have got those, or do you want me to share my screen? I'm happy to. I don't know what the best way is to do it.
Well, they're quite. I mean, the slides are sort of woo. There's quite a lot in the slides, and they're sort of some of them. There is because they're NHS. If I may make a comment, because they're NHS slides, they're almost individual documents by themselves. They require quite a lot of time to read and make your way through. So if you think you need the slides to talk about it, you're very welcome to use them. Or if you just like to talk to the issues equally, you're very welcome to do that. It's up to you.
Yeah, I'm very happy just to talk through. It's not a problem. I don't mind doing it without slides. Basically what we thought we'd set out would be most useful today was talk about what we're looking at across the system in terms of how we think about reducing inequalities. What we want to do, we're a very small team who cover all 8 boroughs, so we work sort of across all 8, and we want to have the biggest impact that we can on reducing inequalities. And I think, coming together as an integrated care system gives us that real opportunity to collaborate to try and reduce inequalities, because it's very difficult to really shift the dial. So actually coming together, we've really got that opportunity to really make a difference. But we're still learning, I think, about how best to do that, how best to work together and have the biggest impact. And we really welcome these sorts of conversations and input from various stakeholders and partners to help us think about how can we best add value and how can we best dial. So
that's really helpful. And I mean, probably it's worth just before you talk a little bit more, it's just defining for everybody what so we're all on the same page when it comes to inequalities, what it is that we're talking about.
Yeah, sure. So the way we sort of think about our program is sort of one of the core part of that is around understanding the inequalities around access to services, around experience, around outcomes achieved across health and care services. So think about where do we see those differences that people are experiencing in those areas, and working really across the system. So think about how can we tackle those. But we also know that obviously access to health and care is such a small part of people's overall health outcomes, and actually those wider determinants of health are really important. So we think about kind of how can we have the biggest impact on those as well.
So just to define inequality. So you're talking about inequalities. You're talking about things like racism. You're talking about people of race. You're talking about disability. you're talking about income. Is that also?
So yeah, so we
Would you like to list give us a sort of list of things that are understood by inequalities?
So when we think about kind of health outcomes, we know there's sort of different building blocks of health affect those outcomes. So that includes things like income, and people's access to good employment. It includes the good built environment, so housing and wider green spaces and things, they impact on health outcomes. Access to care, quality of care, things around health behaviors, so alcohol use, diet, exercise, all these things are like building blocks of people's health, and they all have an impact on people's outcomes. And so we as a team try to think about how we're having impact across those, but obviously the only way we can do that is by working in partnership, because obviously we don't hold all those kind of levers to have those impacts, so we need to work across partners to have those biggest impact. And deprivation is obviously a big part of kind of some of that impact on people's health outcomes. So we think about how do we break down our population, understand what's actually happening, levels of deprivation, understand the impact of, we've got a race steering group, so we think about people's race and how does that impact on health outcomes. So we try to look at this from quite a lot of different angles to try and make sure that we are having the biggest impact.
Okay, thank you for explaining that. Back to you then, as it were.
Great, yeah, and I've sort of touched on some of the bits that I was going to say, but yeah, just to kind of be clear about the kind of the three kind of pillars of our program. So the way we kind of break this down and think about our work is, the first work stream that we have is around really tackling those inequalities that I've talked about. So think about access to care, experience of care, and outcomes. And we use the core 20+5 framework to help us think about that, which is one of those quite jargony kind of phrases. So I'll explain what that means. But what that tries to do is help us give us a way into thinking about inequalities, because it is such a big issue and there are lots of different ways to tackle this. We also, the second thing we try to do is put in place some of those building blocks of population health management. And so again, that's sort of a phrase that we use, but what that is really about is creating a methodology for change. So it's like, how do we think about then, how do we make a difference? So what can we do to actually shift the dial around inequalities by using really good data, really good engagement with our communities, co-producing with our communities, really building trust and really making that change happen. So we try to put in place that consistent methodology, that capability to enable us to make change happen. And the third area we focus on is that kind of partnership, working on those wider determinants. So that's what I was talking about earlier with those kind of different building blocks. So how do we work with partners to improve social, environmental, healthy living factors that adversely affect people's health and well-being? So that's kind of the way we think about our program, is in those kind of three areas. And I've talked already about the wider determinants of health and how important they are to people's health outcomes. So we really do try and think about those wider factors. So it's not just about clinical services that people access, it's about those kind of wider bits. So really seeing people as a whole, understanding what matters to them, really building trust with our communities, understanding what's important, so that we've got those really good insights into kind of what's important to people, and so that we're really targeting the issues that really make a difference. I said I'll talk a little bit more about the core 20+5 framework, so I'll do that now, because I know that is a bit of jargon that we use it quite a lot, but like I say, it's just a framework.
So it's just to interrupt you, just so everyone's clear, it's called core 20+5.
Yes.
Okay.
Yes.
Okay.
So that's a framework that's used across the NHS to provide a common method, a common approach to identifying inequalities and helping to address those. So the core 20, that is about understanding our most deprived 20% of our population. So think about that index of multiple deprivation, understanding who is that group that really has the that multiple disadvantage, really kind of getting to grips with those through understanding that kind of quantitative data. So we've got quite good data sets in Northwest London, helping us to understand those groups, but also through the data, but also engaging really closely with those groups and understanding what matters to them. So that's the kind of core 20, is really getting to grips with that population who could really benefit the most from a more targeted approach. Then the plus is those groups that aren't necessarily showing up in the data. You use plus as a really good opportunity to engage with our communities and understand them better and understand some of those challenges. So really kind of building those insights. And that might be people who are sort of inclusion groups, so maybe suffering from homelessness. They might be having a poorer experience of care. They might be sort of asylum seekers or refugees, or people in the criminal justice system, which is an area that Nikki's particularly interested in, and we're working with her share on that. And so thinking about what are those kind of groups locally, so within here, be like Hammersmith and Fulham, what are those kind of key groups that have a worse experience that we really want to target? So that plus is that gives us that flexibility to kind of really really get to grips with some of those communities that need additional support. And then the five clinical areas that have been shown to have the biggest impact on inequalities. So that is around maternity and continuity of care, severe mental illness and supporting people to have physical health checks, is around COPD and ensuring that people have access to vaccinations, early cancer diagnosis, so stopping people being diagnosed late, making sure we're really diagnosing them early, which we know is a big inequality, and hypertension, and really kind of identifying people with hypertension and supporting them to manage that well. And then smoking cessation is the final bit that kind of cuts across all five, which has a positive impact on all those 5 clinical areas. So that's what the core 20+5 framework is. It provides us a way in to kind of think about inequalities, thinking about the kind of most deprived population, those plus groups that give us that flexibility locally to think about some of those groups that are maybe poorly served, aren't showing up in our data, and the 5 clinical areas that have the biggest impact on inequalities. So we use that to help guide our work. And across the system, we have a core 20+5 delivery group where we bring together people who are working on inequalities to provide that support, to try and mutually kind of help each other in terms of having that biggest impact in inequalities, sharing best practice, helping resolve issues and so on. I mentioned earlier that the second thing we do is think about that kind of methodology for change, that population health management approach. And so what we're looking to do there is really build the capability across the system and that capacity to enable us to make change happen. So building analytical capacity to really understand the data and understand some of the challenges, building capability to co-produce with our communities. So really building trust with our communities, making sure that we're designing things with people, really kind of getting those skills in our staff to help to do that, do co-production, really genuine co-production that does share power and does genuinely make decisions with communities. When we're looking at making sure we've got good leadership skills around population health, good facilitation to bring people together and really make change happen. So that's about some of that kind of capability building, and we're working with the boroughs to understand where they are in terms of their capability around population health and helping build those skills and really embed them as part of business as usual. So this becomes a way of working where we think about people's health in the round and really make change happen in partnership with our communities. I know in Hammersmith and Fulham you've got quite a lot of work happening around inequalities, and I don't know if Linda wanted to say a bit as well about what's going on.
That's helpful. Let's just, before we talk about the Hammersmith, because you've said a lot, which is very interesting, and as it were, quite a lot of thrown at people. I don't know if anybody wants to come in and just ask any questions at this point. It's very helpful, of clarification, just to tease anything out about what you said. If you're all very clear, I mean, a lot of what's been said, you're involved in yourselves. Oh, Yvonne, welcome. Nice to see you here. Yvonne, do you want to just introduce yourself? I just noticed you've joined us.
Thank you.
If you just say who you are.
Oh dear, just noticed my camera isn't up here.
Fine now, good.
Hi. Apologies, I'm Yvonne O'Keefe. I'm the strategic lead on equity, diversity and inclusion at Hammersmith and Fulham Council.
Okay, thank you very much. Good. Well, let's just, as I said, let's pause for and take some comments and stuff, because it's a lot which just been said to us. Lucy, and then Jim, would you like to come in?
Can you hear me all right?
You might be better off without your camera on.
Is a bit dodgy.
Yeah, if you take your camera off, Lucy, it might be better.
Okay. Yeah, I have done. Is that better?
Yes.
I just wanted a bit more clarity on the definition of the 5 areas of health inequality.
Okay.
That you mentioned.
Let's take that. I'm going to do this if it was a big public meeting. I'm going to take three comments at once, and then ask Nicola, because they're all going to be directed at you, to come back on the 3. Okay, thank you. Jim, and then Sue.
Thanks, Chair. What you said, Nicola, I find quite helpful, because when I read the paper, I found it very hard to think it in the context of our own borough, because it's written at such a level of abstraction. And when I went through it, one thing did actually strike me, and it struck me when you were talking. There's a very us-them despite the use of co-creation on slide 7 or 8 and the word co-production, because in practice, what you said, we are targeting at them. So in practice, are we saying that we have a range of ideas we're going to ask you about? So what you've got there is focus group, not co-production. And when I looked at the number of what were the key areas, I wasn't sure how it matched the data for our own borough, because there's a point later on where you're doing a deep dive. But without a deep dive, how does one know?
Okay, I'm actually going to be cheeky. I'm going to take. I've got 4 hands up in all, so I think we'll take all 4 points if you don't mind. That's Sue, please, and then Jackie.
Yeah, I mean, I think we did a research report in 2021 about mental health in the BAME community. And one of the key messages that came from that is the intrinsic barriers that lots of people face in trying to access services in the first place. And I wonder how much sort of research or investigation into that you've managed to do, because we think one of the biggest problems is not just the health inequalities of people who were turning up for health support, but the people who don't seek support until they're much more ill, if you like, or unwell, or until it reaches crisis point. So earlier intervention, what research?
Okay, earlier intervention. Thank you. That's helpful. And Jackie.
Thank you. I suppose my comment is that this appears to be very adult focused. And I know there's a reference to maternity. There's a bit of a gap between maternity and then adulthood. And I'm just wondering, Nicola, about sort of the work to understand what investment in prevention of emotional and physical health, or mitigation of emotional and physical health in children and young people would lead to better longer term outcomes for adulthood. Please.
Right.
Yeah. Do you want me to come back in on some of those then? Very happy to, and other colleagues might want to come in as well. So I was just bringing up, just picking up on the last question, the core 20+5 for children, which I should have mentioned, which I should, so that was an oversight on my part. That's recently been launched. So it's roughly equivalent to the core 20+5 for adults in terms of some of the bits I talked about around understanding the core 20 and the plus groups. But the 5 in the children's core 20+5 includes asthma, diabetes, epilepsy, oral health and mental health, and particularly sort of think about the mental health support for children, young people, and you know, so we know some of the impact that has been negatively in that area with the pandemic and so on. So that provides a framework for children, young people as well. As you're absolutely right that as I was talking before, it was quite adult focused, and I think our approach up to now has been more skewed towards adults, and I think it's great that now we have got a core 20+5 framework for children, young people that gives us a common language and focus to do more work in that space. And we've got a conversation tomorrow at the core 20+5 delivery group, which I mentioned earlier, where we come together to talk about inequalities, to have a start of a bit of a workshop and thinking about children, young people and what more we can do for them around inequality. So we are starting that journey. It feels a little bit further back, but we are starting on that, and we've got that common language now. So I should have mentioned that, but I think that will hopefully be a useful step forward.
Thank you very much.
And then in terms of a couple of the other questions, so the 5 I mentioned around the adults, the core 20+5 framework is available online, and so obviously, you know, do feel free to have a look if you want to kind of understand a bit more. I wasn't going to go into loads of detail about the 5, but we have got work in each of those areas. So I've mentioned before about maternity and continuity of care, particularly for women from minority ethnic backgrounds and from the most deprived groups, because we know that has a positive impact on maternity outcomes. And then we do have differences in outcomes across the different groups. Severe mental illness, the intervention there is particularly ensuring we get the annual health check figures up, and we have been quite low in terms of annual health checks, and that's been negatively affected around COVID as well. So really making sure that we are getting to the kind of target around annual health checks, and we've seen quite a lot of progress around learning disabilities and supporting people to have annual health checks, but around severe mental illness we're much further back, and so there's more to do in that space.
Yeah, that was really the area I was interested in with what Jackie, to pick up on what Jackie was saying about recognizing those mental health conditions, and particularly a very visible group is the sort of high functioning autistic people who might not have diagnoses, who might not have EHC plans, and who are quite difficult to find in the population and quite alienated from GP surgeries, and just wondering what the sort of plans were for those people with those hidden conditions.
Yeah,
sorry to ask.
Yeah, no, that's great. And we are working really closely with the mental health team here. So we're obviously a very small team ourselves. So we're really trying to build that kind of capability, working with and through others as well. So the mental health team in the ICB do a lot of work in this space, and we're working with them to help support that, to make sure that we are identifying people earlier. We know the data does show poorer outcomes around some of our certain communities around mental health, and in terms of access to services and people accessing services late. So it's absolutely an issue that we're aware of, and there is quite a bit of work in that space with that team going on. So that might be something we want to come back to and talk about in a bit more detail. I don't know if June wants to come in on that as well.
Yeah, June, you want to come in on various things, I think.
I was just going to add, so in terms of the intrinsic barriers, and I guess what we're trying to build here is a dual model, because we're recognising that often our approach in the NHS has been very medicalised, but when you go out and you speak to communities and you speak to people in everyday lives, it's very rarely, even when we go out and engage with communities, they come and tell you about their diabetes. They come and tell you all of the other barriers that are going on in their lives, like crime, isolation, fear of going out, etc. So I think, just in response back to that intrinsic barrier question that was raised, so I think the plus element of Core 20+5, this is where this framework really comes alive, because it gives us the opportunity, I guess, to build in what the data doesn't tell us. We're often in the NHS, as you know, very data driven, and what we're trying to do here is balance the data with real insights and lived experience, and show evidence back to our communities, I guess, that we have listened and actually are building that into our framework as we move forward. So it gives our communities the confidence that we're not coming out and engaging with them. And Jim, picking up on what you said yet again, that engagement rather than co-production. I want to be in a position where I go back and feedback to communities. You've spoken to us, you've told us these are the barriers, and this is how we're working in an integrated way to address them. But don't just focus on the health element, because that's not how people's lives are.
Okay, thank you. I think Linda, you wanted to come in as well on that.
Yeah, I think the point that's been made about it being very sort of medical, clinically orientated is a valid one, and I think that's something that we've got to work on together, both an ICB level and a local level. I think for me, things like diabetes, etc., are symptoms of poor inequalities, and actually we need to get to that. What is the root cause? Whether it be housing, income, employment. And actually, I think the bit for us is that what is the +5? So, the +5 for every locality, but will be very, very different. So we've already started some work around our Black communities and building trust, and some of the messages that are coming up through there. We know we've got a big issue around housing. And in fact, Helen just popped in the chat about Helen's the lead on the mental health arm of our health and care partnership, and in that we are picking up some of the issues for younger people in mental health, as well as for those people with severe and enduring mental health and physical illness as well. So I think the key for this is that we say, what does this mean for Hammersmith and Fulham? Interpret it in a Hammersmith and Fulham language. And then, as Jim or Meryl, sorry, apologies, either of you, I can't remember, said, it's about how we then co-produce what it is that we need to do that's going to make a difference for our residents in Hammersmith and Fulham. rather than just focus on how much maternity affects people or diabetes, because that's a symptom rather than the cause.
Right. So let's look at Hammersmith and Fulham then for a sec. I know that we've already started doing a piece of work which I've
had my hand up for a while, Ben.
Oh, sorry, I thought it was a legacy hand because you'd already asked a question. But it's a new hand, is it?
Yes.
Okay. Sorry, Meryl. What is it then? Do tell us.
I think it's quite an important point that I want to raise, because it seems to me that there's very little data actually here, despite what June says. And we're given figures like 20% and so on. But actually, it's not local data, is it? That's data that presumably has come from NHS England, so it's a sort of global figure. And I think that what we need is some much more specific data that relates to the local population. Indeed, for the next item on the agenda on dementia, some work was done in 2021 that indicated Hammersmith and Fulham has, without any explanation, so explanations are actually needed for the data as well, but a whole range of risk factors, for example, for dementia. Hammersmith and Fulham's position as a London borough varies hugely, and in some cases, the risk factors for Hammersmith and Fulham are very, very low. And I think it's important that we have that information and that we try and find reasons for that information, because otherwise we may be aiming at the wrong areas. So I think this is quite a data poverty poor paper, and that we need more data that is to pick up Ben saying we should go local, that needs to focus much more on the local. And then when we have that data, shouldn't residents themselves be helping to decide what the priorities are, as well as being involved in co-producing solutions?
Thank you, Meryl. I'd like to actually bring Nicola in at this stage, because part of your job as Director of Public Health, Nikki, is data building, and you've been doing a lot of that recently. And maybe come in on what Meryl's been saying.
Yes, thank you, Chair. So I've just put in the chat our joint strategic needs assessment fact sheet on diabetes. We'll have similar fact sheets on a range of topics. And as Meryl has said, it's about local data and relating them to poverty in our borough. We have drilled down, and we've got really interesting information in some places about exactly which parts of the borough are affected by certain conditions, like asthma admissions in children, which I've got a great interest in, and clean air. So all this kind of thing, if you feel that anything is missing, Meryl, do tell us and we can add it to the joint strategic needs assessment. It's really just like a statistical compendium. But yes, we would look to colleagues like Nicola Kay and June to give us the big picture of Northwest London, what they're looking at, because we really benefit from those big pieces of work. But then at a borough level, we have this kind of detailed work. But if you, I'll message you separately, Meryl, if you think there's anything missing that you'd like to see, we'll just get on it straight away.
Thanks very much, Nicola. That would be really useful.
Yeah. What about Meryl's point that it would about developing it with residents and checking its meaning and its validity with residents?
That's a great idea. We have attended diabetes meetings, and we work closely with the Diabetes Association in the borough, just on, well, things that are really big for them but might sound small to you. So finding them locations where they can meet to have their coffee mornings, making sure that it's accessible. There is they call it a campaign group in the NHS. As Councillor Coleman said, Hammersmith and Fulham Care Partnership has a number of, I'm going to call them priority areas, they call them campaign groups, and diabetes is one of them, and they do a lot of work. So through them, we work with their patient group. But you're right, Meryl, we could show the fact sheet to them and pass it by them and see if they like it. It doesn't say, and then so we must do such and such. It really just gives a snapshot. But the bits on poverty are really interesting because more diabetes in our poorer folks, which is really sad.
Good, that's helpful.
Type 2.
Thank you. So that's helpful. So I'm going to go back to Linda now to talk a little bit about what we're doing. So just before we do, and I was starting to say about, particularly around race, that we've started to do building trust, the aim of which crudely is because we became very aware that people of colour were particularly it was worse if getting access to health and other services, and outcomes are worse. It's very well known. Rather than just produce yet another report, and it's not to say the reports aren't useful, they're useful if they're acted on. We would actually try and give residents of colour the chance to speak directly to, you might call it people of power in the National Health Service, significant people quite senior up in the NHS, and so that they would hear directly from residents the challenges that they're facing, which they think are facing because they have to have a different skin colour. And that would lead to change. And we've been doing a lot of work talking about how we can get residents so they're prepared to be in a safe space to tell their story, and also training up the NHS people so they don't feel they need to justify themselves, respond to every point, but listen and build trust in the way they conduct it. So that's one piece of work which I know, Linda, you're working on, and we're going to be hoping we're actually going to be kicking off those meetings, which have been a long, careful preparation. But is there more that you'd like to say? Adds to that if you want, and anything more you'd like to say about the work to tackle inequalities, and perhaps give us an idea of really how advanced in the broader inequalities work the Health and Care Partnership is, and whether it needs a bit of a nudge from the Health and Wellbeing Board to do more in this area.
So I think in the presentation there is reference to what the local Health and Care Partnership is doing. I think it's fair to say health inequalities is sort of running throughout each of the campaigns, as Nikki has just made reference to, and I know Ellen will talk about the work that they're doing in the mental health campaign. I actually feel that this is an area, and it is an area that we've been talking about, health inequalities, that I think we need to up our game on a wee bit, if I'm honest. I think we could do more on it, and perhaps, tonight is the time for us to get a bit of a kickstart on that. And I take all the points that have been said, look at the data, what is the data telling us, and have that conversation with residents, because what I think is the important factors to residents may be total opposite to what residents think. And I think that's a really, really important point for us. And also the big learning point for me, certainly through the building trust work that we're doing, is about how do we engage people in communities that other people trust, to engage them as well. And I think we've got to spend a lot of time understanding our communities, the makeup of our communities, and also who are the trusted voices, to then have serious conversations with people about what does health inequalities mean, because actually as a word it is meaningless to people. People don't think that, because I'm poor, my health is actually going to be any worse off than anybody else. But in fact, people don't understand that. They don't understand where the cause of their ill health comes from. And actually there are some things that we could do which are fairly simple that people could do themselves, and there are other things that we need to do as organisations to change the people's behaviour, and also what the types of services we commission for them.
Right. Okay. Well, I think that's provoked a couple of hands have gone up. So let's take a couple more views. I think I'll see Sue if it's you or Jim first. Sue, why don't you go first? If that's okay, Jim.
Thanks. I just wondered, when we look at the key clinical areas of health inequalities, plus those campaign areas that the ICS as well has identified, how have those been prioritised? Is it those health inequality issues that most impact the most of the population's health and well-being, or is it more financially driven? These are the conditions that cost the NHS lots and lots of money. So, for example, you've got severe mental illness on the core 20+5, but I would imagine a lot of residents would say, well, actually, it's lower level mental health that has a huge impact on people's lives and they feel there isn't enough support for them in the community, etc. So I'm just wondering how those priorities, those key issues have been identified. And as the point that Meryl said earlier, it'll be really interesting to get residents' feedback on the issues that they think should be focused on. And I don't know if there's any leeway. It could be national NHS saying this is what you most focus on, but what's determined those priorities?
Before I bring Jim in, I just think it's worth just understanding that what's determined the priorities. I'll bring you in, Jim, but June or Nicola, I don't know if you want to just say that.
Nicola, do you want me to answer?
I can say a bit, but then June, you probably want to come in as well. So my understanding of the how they've been identified isn't to do with cost, but to do with where we see the biggest inequalities impacts. So for example, for early cancer diagnosis being one of the 5 that's been identified, we see that for people from more deprived populations are being diagnosed much later and in A&E, and so in kind of more stage 3, 4 of cancer rather than at stage 1 and 2. So that's why that's been identified as an area where you see a particular inequality, and therefore we can make a big difference by more proactive identification of cancers, better diagnosis within communities, because there is that difference between what services different communities are receiving and therefore when the diagnosis is happening, and so it's leading to much worse outcomes. So it's more about the outcomes that people are seeing, the access issues, the experience issues that people have, that it's differentiated between the different communities rather than specifically a kind of cost impact, though there may be a cost impact through making a change to those areas. That's not been a particular driver. So that's my understanding of how those 5 have been identified, and that's sort of nationally. That's a national framework that's been provided, and therefore we want to do work in that space because it's evidence. But locally, people will have their own priorities as well, and that's providing flexibility.
Okay, I think I'm getting to what I said. June, did you want to add to that?
I was just going to say there's always local flexibility. Those are our 5 national mandated ones, Councillor Coleman. But if you think we also have some prioritisation across the ICS, we've encouraged all of our programmes to look through an inequalities lens.
Yeah. Let me just ask then, June, you've got this, you've decided in the NHS, right? We're in this crazy new world of the ICS. Yeah, we're in a crazy new world where we're working to integrate all the different parts of the NHS. Good luck. And we're trying to integrate across councils, 8 councils and the NHS. And we've got this. We've been working together, obviously, some time on this. But we've got how much councils really bought into the 20+5? Because if you're saying at the local level we have the flexibility, it seems to me we have the flexibility to add yet more things, or do we have the flexibility to ignore certain of the 20+5 and do what we think matters?
So I think unless you've got some strong evidence, the 5 are nationally mandated and they're evidence-based. But I think the 20% is down to local definition, and we'd be working with people like Nikki and like Linda on the call to define that. But I think, the real flexibility for me is around the plus element. If you look later on in the slides, one of the last slides is about making sure that we start having some joint local workshops to start looking at whether we've got our priorities right, whether the data follows the prioritization, and having those conversations. And I've just had a conversation with Linda, and that's really down to local flexibility, who you want involved in those local conversations. That's not ICS driven. We're there to facilitate and support the conversation and give people some of the evidence-based, as Meryl said, the data right down to awards level. And I really, really want to challenge people. Have we got and have we chosen the right priorities? Have we built in the insights from our communities? Have we gone out and engaged what matters to our communities at a local level? So there's a real opportunity there. And I think, my plea to Linda and the rest of the team on this call is really, it's up to the local health and care partnership and wider stakeholders, how they want to shape that workshop. It's an
Okay, that's interesting. That's helpful. Jim, did you want to come in?
Yes, indeed. And I think what June said is actually quite useful, because I think the points made by Linda, by Nicola, and by Sue about priorities and about how they're identified are key, because you can't prioritize everything. Priorities means making a choice within a gamut of factors, and there'll be time, money, staffing involved in this. So it will be a choice where to put all of those resources. I think the important thing is, if we're to make change here in our community, we must know there's a buy-in by people because they feel that is their health priorities. So what we've been landed with 5 for the national NHS, but Britain's a very various country. We're quite a varied borough, a small one, but quite varied. If we actually do find there are several ones which are not on this list, I think we have to strongly say this is where our effort, our money, our staffing will go, and we must bring people with us. So I have a second thing to ask, and that is that when we engage with different parts of the community, we need an assurance that what people come up with is actually built into the rolling out of services locally, that it's not simply a noted, spoken back to, and then archived. It actually leads to genuine change. And that's where you get trust, and the trust itself drives change, but people only buy in and stay in if they actually know that what they've talked about in a group actually will be taken seriously and will become part of our local furniture.
Yeah, and well, let's talk about that for a second. Let's talk about that for a sec. We touched on what we're doing, building trust with people of colour, but I think I'd like to just use the time left on this to talk about a bit less generally, a bit more specifically, how are we going to reach out as a borough through the Health and Care Partnership? Well, let me put it differently. I hear that we're saying that we're sort of looking at this in the Health and Care Partnership, but probably it will be helpful for the Health and Wellbeing Board to recommend to the Health and Care Partnership that they engage fully with the inequalities agenda. I think that's what's coming through, is they're doing some work on it, but it's not necessarily formally and as strongly on their agenda as it could be. If people agree with that, would you be happy to recommend to the Health and Care Partnership that they engage fully with the inequalities agenda? There's probably a prettier way of putting that, but you know what I mean. Yeah. Okay. Well, let's make that a recommendation. And I think my understanding is that this means engaging by working directly with residents rather than coming up with the solutions by ourselves. That's also something which we agree. Yeah. I was going to move on to say, so how would we go about that? But actually, I think it probably is better if we give the Health and Care Partnership some time to talk to residents. It'd be good if they could talk to Hafsan as well and others and come back with a way forward on that. But Linda, I see you've got your hand up, so you may wish to comment.
Yeah, I can see Councillor Richardson's also got a hand up.
Am I just check, Lucy, is that a real hand? That's been up for ages. I thought it was a legacy hand, but is it a new hand?
No, it's a new hand.
Oh, forgive me, Lucy. Okay, well, why don't you speak and then, so forgive me. I thought
it's
it was
a new hand.
It's a new hand. Well, Lucy, go for it, and then we'll bring in Linda.
Yeah, well, actually, it is relevant to what you were saying, actually. No, it's quite a specific point. I was slightly worried that it's too specific, but picking up on what Nikki Lang said, mentioning cafes, and I wanted to talk about the practical points about co-production, engaging with the most vulnerable in our community. And the experience we've had with the autistic community so far is that the importance of space and place are really important, that they have somewhere that they can go to, that it's in the community, and it's earmarked for them at a specific time where they're comfortable. But identifying those spaces and places and paying for them is something that needs to be planned for, and perhaps something that could be done in conjunction with the NHS economy, of our economy department and social care.
That's a very specific. It is a very specific suggestion, Lucy, and I think it's something which it's a very specific suggestion, and I think it's something which is worth taking out of this meeting and bringing it forward, maybe through the Health and Care Partnership locally. It's not something which, if the Health and Wellbeing Board, we can make a specific recommendation on, because it's a very specific thinking. But I'd like, Linda, if you could take that up and we'll talk to Lucy more about that and how it might work in a council and NHS way.
Yes, certainly, and I think it's really a perfect time, really, isn't it, to have this conversation, because we, previous to this agenda item, Meryl had talked about the engagement of residents. So I guess it's for myself and a couple of other people on this call who are also members of the exec. Excuse me. To take back to the exec about how are we going to implement the health inequality strategy at a local level, and how do we involve residents in that through co-production, so it's a meaningful way that's meaningful for residents, so they understand it, so that we understand it, and we also put our plans in place and our priorities together, of which part of that, Councillor Richardson, will be how do we actually provide resources to allow people to meet, etc., etc.
Sorry. So if I can draw this part of our meeting to close, I think we've agreed that it's a useful discussion. It is quite jargon rich. I think when we come back, we probably want to talk about. We're making the recommendation of health and care partnerships. So the next thing will be for the health and care partnership to come and talk about what they're doing in very practical terms and try and translate this into more. I think if a lot of people watch, I mean, inevitably we use a masses of shorthand, because although it's long, the conversation we've had, it could be 10 times longer if we didn't. But sometimes also we use so much shorthand that we all think we agree on the same thing. We may actually mean different things. So let's come back, Linda, and talk about what we're actually doing. The residents we're going to be, either the residents we're going to be speaking to, meetings we're going to arrange, how we're going to go about it, very nitty gritty, so people can feel that the broad things that they're saying about co-producing, discussion with residents, what we're actually doing in practical terms is what they thought we would be doing. And if we're not, then they can talk about that and what would be better and what could be different in that. Yeah?
Yeah.
Okay. That's very good. Well, thank you very much. Thank you very much. Thank you both, June and Nicola, for coming and talking about this. You're very welcome to stay for the rest of the meeting if you wish to. If you need to go and whatever one does at 7:30 at night, eat dinner, you're also very welcome to. We're going to talk about dementia now, where there's a week, which is I'm very glad we can do. We started at the Health and Wellbeing Board. I'm sure I'll be reminded exactly when, but we had a great conversation about what the borough is trying to do and the residents involved with that, and the Dementia Commission and the work that we've done. But we had a great discussion at the Health and Wellbeing Board about what's happening. It was a very nice conversation because people were also sharing a lot of their personal experiences, and I think it helped us move things along. But we did say that we'd want to understand what's been happening in the borough on dementia, and that's what we're going to be doing now, and celebrate some of the things that are happening, as well as get a report to understand where we go next. So who's going to lead on that? Toby, you've been doing, we're very, very grateful that you've come from the wider NHS to lead on this piece of work with the officers and the residents here. Are you going to be leading on the conversation now, kicking off?
So I think the choreography is Joe and Peggy are going to kick off with some of the slides, just recapping some of the things we've done over the last year. And then I'll start to talk through the report that hopefully everyone's got a copy of, and some of our reflections and learning from year one of the Dementia Partnership Board, if that sounds.
That sounds a very good choreography. So over to Joe and Peggy. Thank you.
Thanks, Councillor Coleman. Thanks, Toby. Peggy and I like a bit of dancing around, so choreography is a good word for it. I think we were going to get the slides up on the screen, weren't we, David? Just so we could actually have a look at them in real time. Thank you. Thanks, David. That's great. Okay, everyone. So the set of slides very obviously just give you a sense of what we've achieved in this first year of our implementation plan. We had some brilliant images and just thought they kind of bring to life some of the things we're most proud of. If I could have the second slide, please, David. So just to recap, read them out, but year one priorities. So we honed down the co-produced priorities from our residents, our stakeholders and our businesses to 5 priorities, the overarching one being getting an early and accurate diagnosis within clearly understood timeframes And priority 1 to 4, we were really pleased to agree when Toby started as our chair, because we felt that we'd be able to develop some tangible actions that people could see, feel, touch, and that would be able to bring to you some good news about the difference that those actions were making on people's lives. So if I can move to the next slide, please, David. So this is our dementia guide, which Dementia Action Alliance have led on with engagement from other partners as well. And it obviously addresses priority 1, but it's a critical piece for us because it brings together and celebrates really the partnership that we're working within the board, but also it's critical that we're able to get the guide to as many residents as possible. And we've been honing that over the last year or so, how we get information out to residents, working with housing, social care, the voluntary and community sector, libraries, leisure services, cultural services. But critical for this piece is actually getting the guide to those residents that are known to the memory clinic, so that they've already received a diagnosis or that they're on the waiting list. And similarly, as important, getting the information to our GPs and primary care and those listed on this slide is as critical. It'll be good to go anytime now. It's a fantastic piece of work, and we'll be launching it in Dementia Action Week in May. Next slide, please, David. Many of you were at the Dementia Fair. It feels like an eternity ago, but it's under a year at the very beautiful SEAC Centre. We were overwhelmed with the response that we got for the session. As I said here, we had over 20 organisations and around 150 residents. It was full to the rafters, and it was a really great launch pad for us in the early days of the Dementia Partnership Board. And it's where we began the conversations with our residents that have become our future co-producers and very much engaged in wider events for older residents. So yeah, we're very pleased that we launched via Dementia Fair. Next slide, please. And this slide is captures the Dementia Fair and our resident Dion, who was reading a poem here around her experience with Turtle Key Arts. Was really powerful. And I think she was just, describing her journey. And Dion has been really influential for us in describing how she experiences services and support. And she's quite a straight speaking woman. And that's always welcomed, isn't it? You know exactly where you are. As you can see here, though, it was a great event. See Council Cone in the top corner there. And we are looking forward to many more events of its kind. Next slide, please. This is an incredible piece of work that Peggy instigated with the brilliant innovations in dementia. I think we've talked about co-production extensively in the Health and Wellbeing Board and across the council, and with all of you represented here. In my experience of co-production, which is fairly extensive because I'm old, I've never been involved in a piece of work which tackles the barriers of understanding that you can reach residents with dementia as equal partners, as well as their carers, which is the more common piece of co-production. If you have the right kind of expertise, the right kind of experts working with you. And this photo just sums up a brilliant session that Peggy and Damien from Innovations in Dementia, who've done quite a bit of work in the north of England, did with a group of our residents. And all the stakeholders on the DPB were involved in recruiting these residents, and they had a thoroughly good time. And they're going on to work with Damien. They're going to be our future co-producers. And we've got a series of sessions planned with them going forward, but are also really proud to announce that Sam Piers-Keeney, who works for West London Trust, who's their new engagement lead, will be our future facilitator for this area of our work. So that's another great bit of partnership working. Next slide, please. Once again, we've talked quite a bit at the board previously, but in other situations as well, about the joy of art and creativity in bringing people some respite and support and opportunity to refine themselves. These art sessions have been running for some time now, going really well. Once again, new partnerships with Bishop Crichton House, really exciting opportunities for the residents that have attended these sessions, 84 residents, and joy of joy, being a Northern woman, 624 residents have accessed our dementia-friendly bingo. We love bingo up north. I think that that's just a fantastic achievement. It shows how word of mouth works in a small borough where we all know everybody. So I'm really proud of that area of our work as well. Once again, really important that residents that are waiting for a diagnosis, they've seen a GP, and that they're engaged and that they get to be part of the family as early as possible. Next slide, please, David. And this presentation wouldn't be anything without Imperial, and this was a great day. We had the fair, and shortly afterwards the UK DRI launched their technology centre. It was a fantastic day, and we're so proud to have Imperial DRI on our doorstep, and we're going to go on to say a little bit more about them further down the line. But research will be a key part of our year 2 implementation plan. It's been a key part for year 1, but we're hoping to really hone in on research in the second year. And to those ends, we've got a research presentation tomorrow at the Dementia Partnership Board, which we're thoroughly looking forward to. Next slide, please, David. And this is my last slide, and then I'm going to hand over to Peggy, but this is on the front page of our dementia strategy. For Brian CIC, instigated some amazing piece of work with Bike Works, which supports not only residents with dementia, but residents with learning disabilities and other disabilities, to get out and about and be visible and active in their community, and to have fun. It's a really inclusive piece. And now working proactively with the Ash Church Centre and Angela Mooney to further their work, but an incredible piece of work and something we'd like to celebrate more going forward. I'm going to hand over to Peggy now to do the remainder of the slides. Over to you, Peggy.
Thank you. Can everybody hear me okay? Yes, okay. So this slide is about a new initiative to add memory cafes to the borough. It's called the Tuesday Club. Previously, we just had one memory cafe, which was on a Saturday at the Alzheimer's Society. So we invited organizations to partner with this initiative. And now we're going to have a memory cafe happening somewhere in the borough each week. So it might not always be on your doorstep, but you can take public transportation to get there at Edwards Woods with our new Nourish Hub. I will be part of the activity there, lending some dementia expertise. On the first Tuesday of the month, the second Tuesday of the month will be at HUK and Greyhound Road in Fulham, and they're partnering with Visiting Angels, a private care agency. On the third Tuesday in the month, one of our day centers, Elgin Close Resource Center, will be hosting a memory cafe, and their partner is Walfinch. And then on the fourth Tuesday of the month, which isn't a Tuesday, it's a Saturday, the Alzheimer's Society will be having their memory cafe. So memory cafes are a very traditional place where carers and people with dementia can go for information, socializing, and peer support. This is a big deal for us to take a bite in adding 3 at the same time, but the power of the network really should give our dementia community a real chance to get out, get active, and to be a part of the community. Next slide, please. So this is the happy, look at all these lovely colors. So far, we've had 3 or 4 of these events. This is a dementia-friendly event, fully inclusive. This is for our older residents. And this is about really looking at supporting the carers and people with dementia within the greater umbrella of older persons, so that we're not ghettoizing this community, and we're offering support both to carers and people with dementia to be engaged side by side in each and every activity that they want. So choice and control. Next slide, please. So I'm there. There's a picture of me there. This is an initiative that was made available in Hammersmith and Fulham last autumn. It's an immersive experience. It was amazing. I think the most amazing was when I saw both BIN people as well as students of Lady Margaret's going through this experience, where by depriving your senses, you might get a feeling of what it's like to really have dementia. So that's what this was. It's very effective and used by many boroughs for social workers to get an understanding of what having dementia really feels like. Next slide, please. So here's Westfield on World Alzheimer's Day. It was great. The location was right next to Boots. And this is about getting the message about let's start conversations. So dementia awareness, people came up and wanted to talk about symptoms, concerns, how do I find help? In Hammersmith and Fulham, we don't have a door that's open for residents to come in. So this was a great opportunity in a very busy place. Next slide, please. Oh, this was so exciting. So this is a photo of a lecture hall at Imperial's medical school. These are 314 students that we did a Dementia Friends session with them. One of the videos that's been prepared by the Alzheimer's Society, it had a lot of us crying. But the people you see here are 314 newest dementia friends in Hammersmith and Fulham. Again, the message about increasing awareness, which supports increasing conversations about how people can help, what the symptoms are, if you need to maybe consider going to see your GP. Next slide, please. This is a copy of a training certificate. It's very exciting. Some of the social workers in LBHF, adult social care, followed through with a demanding training course, and they now have a level 2 award. The idea here is that we are supporting all the staff to have the appropriate training. So for some of the local authority staff, it'll be Dementia Friends. For others that are involved with people with dementia on a daily basis, it will be a more arduous training. And this was a great result for some of our adult social care employees. Next slide, please. So this is really about the beginning of how many Dementia Friends can we make. This was at the Dementia Information Fair in May. And what all these faces you see here, at this time next year, you're going to see postmen, you're going to see bus drivers, you're going to see rubbish collectors, you're going to see bank managers and newsagent managers. So this is going to be, you're going to see football clubs. So this is about really putting forward the notion that every resident, every person that works here or comes to Hammersmith and Fulham can play a role, and they can make a contribution to creating a dementia-friendly community. And finally, if I could have the last slide. This is super exciting, super new. So this is a lovely organization called Fulham Good Neighbors. They are an award winner, the Queen's Award for Charities. But they distinguish themselves in a way that just has blown me away. They wanted to have more training for their staff and for their volunteers that are befrienders. And in the process of having that conversation, they said, well, you know, we work with a couple pubs. We have like a silver Sunday, I think they call it, with 4 pubs, and we're friendly with other businesses, and we're a part of the Fulham Business Improvement District. And we would like to host an event whereby dementia understanding, dementia awareness, dementia activation is made possible. So this is an example of increasing awareness about dementia, but also the fact that this organization stepped up to be a convener. How about that for a fancy word? Okay, so we now have conveners for dementia awareness in Hammersmith and Fulham, and Earls Court Development Corporation, Queen's Club, the Nuffield. I mean, everybody is so excited about coming to this workshop. So it's very exciting because it's talking about dementia to organizations, to groups, and to businesses. And the people, the lead presenter is the head of the dementia team at the Imperial Hospital Trust, Jo James. So she's a member of the Dementia Partnership Board, and you're just in the best hands if you're with Jo James. So this is a great result.
Well, Peggy and Joe, thank you very much. Honestly, if we didn't feel enthusiastic before, we certainly do now. And it was very uplifting indeed. And we're going to have a conversation, but I'd like Toby to give you the chance to finish, as it were, setting the scene just before we say anything. But again, that was brilliant. I feel very uplifted. Thank you.
Sure. Thank you. And I'll be fairly brief. I think just a couple of things that I wanted to kind of pull out and kind of reflect on from our first year. I guess in terms of genesis of the board, I think this is atypical in terms of a piece of work to get involved in the sense that it very much grew from the work that was led by local residents. And I think that philosophy of co-production has really underpinned the work that we've tried to kind of engender over the course of the first year. And I think it's kind of really important that the Health and Wellbeing Board continues to kind of back that approach, because I think you can see in terms of the breadth of relationships that have been developed over this year, that connection back to local residents is pretty fundamental. I guess the bit we've tried to overlay onto that over the last year is a real sense of kind of how do you get stuff done. So I think that the strategy was a really important starting point, but we needed to be quite purposeful in kind of prioritizing down into some really clear, tangible things that we thought we could get done in the first year. And also to kind of build the relationships across what is quite a complex set of partners in Hammersmith and Fulham. So, you know, the kind of community voluntary sector we've just covered, but linking those guys with the statutory services in both the NHS and the local authority, and then bringing in the research side of things is quite complicated. And everyone speaks a different language, and everyone has a different way of describing the same problems. And I think that's been a real kind of learning exercise for us in terms of how you bring those different worlds together. And it also takes time. I think we have not fixed all of these things yet. We are definitely on a journey. And I think it's really important to give these kind of relationships and programs time to really kind of build those relationships and trust. I think you've just heard a little bit, and the report describes more about this, the kind of breadth of connections that have been developed across the borough. And I think that network stands us in incredibly good stead in terms of moving into year 2, because you can leverage all those relationships to really create the kind of value for local residents. There's a couple of things that I wanted to reflect on, which I think are both lessons for the work on dementia, but also lessons for the Health and Care Partnership more broadly. And there's 3 things I wanted to pull out on that topic. I think the first thing, which we talk about in the report, and Suhana and Helen may wish to kind of jump in on this as we get into questions, is we continue to have a big challenge around diagnosis rates in the borough. And West London Trust, and just to say, I think have been increasingly really involved in working alongside us in the partnership in a really productive way. So I just want to call that out. But also important to note that on diagnostic rates, it's quite a complex problem to unpick. And actually, it goes all the way through from really understanding the community and the people that aren't coming forward to general practice, through to working alongside general practice, through to working with the memory clinic. And it's the kind of complex problem that requires a partnership to really make it operate effectively. I would say there's also a note there for the CCG in terms of commissioning West London Trust to increase their capacity to meet the national diagnostic standard, but I will perhaps leave that for another day. On governance, I think the partnership board, in the way it was set up, I think there's an ongoing question about how it connects properly into the health and care partnership and how it competes alongside some of the other priorities for the health and care partnership for resources. As you will know, many of us have been involved in this very much on a kind of voluntary basis over and above our day jobs. And I think that's really important to note. And actually, there's only so much change that the health and care partnership can affect in any given year. And I think it's just worth kind of reflecting on that in terms of where this sits alongside priorities going into year 2 to make sure we can kind of right size our ambitions on this. So perhaps that's one for questions. And the other thing that, again, we covered in the report is data. I think this came up a lot in the last item on health inequalities. You are absolutely blessed with a wealth of data in Northwest London that is seemingly impossible to access. So you have a brilliant kind of linked data set, and it's taken us about a year to get a meaningful extract of that really starts to tell us what's going on for people with dementia in the borough. But that is fundamental, and I guess the final point that I'd say in relation to how the health and care partnership kind of picks and runs with some of this is just real clarity on change methodology. Kind of how do you actually affect the change you want to see, and what's your process from getting from A to B? And I think data is a big part of that, kind of aligning priorities with resources, with people, with really clear focus, etc., is something that I think we've grappled with over the course of the year, and we've made some great progress on. But I think it's just something to reflect on in terms of how that works going into year 2. So huge amount of progress, huge thanks to the team, not just to Peggy and Joe, but the kind of wider partnership board for all of their efforts on this topic. Loads of learning and loads to reflect on, but also I think really exciting and kind of optimistic about where this is going to go in its second year. I'll stop there.
Toby, that's really, really helpful. Thank you. And I don't know what we're going to do without you to chair the board. I really appreciate. I think we all really. I've got lots of hands up. I'd just like to say a couple of things first. I think we all really appreciate the fact that we have not just in this borough. And Toby, you began in this borough, but you moved from the CCG to Imperial to other things. Now Watford, is it? But we've been really fortunate that you've given your time to this, and we're really grateful. I just would like that to be noted on behalf of the board in the minutes, how grateful we are that you've chaired the work. I continue to be. I think you've really drawn out something about the relationship between the residents. I mean, Peggy Coles, when she first came to me when I was elected as a councillor, and said, you've got to do something about this. And where we are now, it just shows that we haven't got the determination of individual residents to really work with us and make things happen, then we wouldn't be where we are. And equally, I have to say, if you haven't got and I'm not trying to blow our trumpet here, but if you haven't got an administration politically which wants to work with residents, and you haven't got fantastic officers like Jo and her colleagues who really also want to work with residents and just see them people to be managed, which is not our officers' approach. If you don't have all that, then you don't get where we are today. So I think we've been very blessed that it's all come together. And a tiny thing I'd also like to thank, if I may, my colleague Asif Sadiq, who's our new councillor champion for older people, and he just said, effectively, you mentioned the silver socials, and he just said we need more jolly events. Not just to talk about improving, which we'll come this part, Tony. I want to come to very specific things about services and delivery, but not just about those sort of things, but just bringing people together, have some fun. Where goodness knows, times are unfun at the moment in the country. It's not a lot of fun. So I'm pleased he's been doing that. And Jo, again, you and your colleagues, thank you for stepping out to use the dance term, because I know you and Peggy have been doing some of that at those events as well. I want to bring people in, but I would like to also not to lose the opportunity. Maybe you could pick that up in your comments. I think there are some very specific challenges which the report and Toby's drawn out of the report we do need to consider as a board. And the issue of diagnosis is huge. We do need to address, and I think why diagnosis is not as good as it could be, and whether more funding from the CCG for the West London Trust to increase their capacity to meet the national diagnostic standards is necessary. One thing I'd like to explore a little bit, if anyone would have comments on that. The second thing I think, Toby, that you talked about is that the health and care partnership. I think it's extremely important that we as a board say to the health and care partnership that we want them to support the work on dementia, whether or not they they fit it in the campaigns, to use this very NHS word that we now have to use for our health and care partnership, whether it not formally fits their campaigns. We'd like dementia to be a priority for them. Again, is that right? Would you like that as a board? Let's talk about that. And then data. It is a shocker that everything we do, as you say, whether it's clarity on change methodology or everything, we've got to have good data, and we've got to have access to the data. And if we haven't got access to the data, can we talk a bit about why we haven't got access and how we can unblock that? These may sound like quite technical questions, but I think we do need to. I'd like to bottom them out a little bit at this. We're going to finish at 8:30, and I'd like to bottom them out a little bit as we talk. So anyone who wants to come in, you may have more questions to ask, but let's have a quick round of people. I can't see what order people put their hands in, but I'm going to take someone who's been quiet so far first. So it's Sahana, followed by Nadia.
Thank you, Councillor. I guess just a few things. I think the limiting factor going forward, if I'm going to be completely honest, in terms of dementia diagnosis rates and sort of the success of the partnership going forward in terms of dementia, is going to be primary care engagement. So coming from a different trust where we had similar issues with dementia diagnosis in Kingston, primary care engagement was a key factor because they are the people that are referring in the patients. So there is something around that for me going forward. There is something about how this ties in a little bit with health inequalities, and that we know that there are certain populations that aren't seeking help. So being a bit more active about that. Yeah, I think for me, it's really around engagement. In terms of funding and the CCG funding, yes, I think that is part of the puzzle, but that won't improve anything if we don't have the GP engagement, which I feel that we're lacking.
Good, that's really helpful. I'm going to just all of you get your hands up. I'm going to focus on diagnosis for a minute, not other things. So if you've got other things you want to bring in, I really want to have them, but I'm going to focus on diagnosis first, if that's okay with you. Primary care engagement being an issue. Just remind me, what is the, I should know this, as the chair of the board, what is the primary care representation meant to be at this board?
Sue Rooston.
Just Sue from part of the CCGs. Okay, I think that's probably not sufficient. And we ought to see if we can get more clinical leads from primary care networks. Meryl, do you want to say something on that?
Yes, I do. It was one of several points I wanted to bring up. I think that there's a big problem with primary care representation, particularly if we're talking about the GP side of primary care. Ever since PCNs were set up, the federation disappeared, and the GP Federation was the mechanism whereby other bodies could communicate with GPs as a group. And I think it's happened not just in terms of dementia, but in terms of a whole range of other issues where there is nobody that represents GPs as a whole. And I think that is something that the Health and Wellbeing Board needs to be raising. I don't know what the solution is.
Okay.
The loss of the federation is serious.
Okay. I would like to come back, David, if you could remind me, I want to come back at the end of the meeting to talk about primary care anyway and GPs. So we just remind me that, because we can note that as one thing we look at when we talk about GPs. But on the diagnosis, so primary care engagement is a problem. How can we engage better with primary care? How can there be better engagement with primary care? I want to just turn on the diagnosis of the primary care issue, if that's one of the main issues. Would anybody have any suggestions what we as a board can do, or in the borough we can do to improve that? Sue and then Jim.
It's not specifically in response to that, but it is also
okay, well, I want to take things in response to that at the moment, because we haven't got much time, so I'm going to be quite directional, if you don't mind, at this stage. Just on the GP issue, how do we get GPs to engage more on the issue of dementia? Is it something that, because it's not sufficient, is it insufficiently on the health and care partnership agenda? Linda?
Yeah, so I think we lost something when the ICB started. Because if you remember, we used to have James Kavanagh sit on this board, and that's been lost. I think there's also an opportunity in two respects. Either through this board, there is a GP clinical leads meeting every Monday that we could engage in, but we've also got the training partnership, which was the federation, now focuses on GP training. And we've a route in there through Carolyn Durack. So I'm happy to take this away as a challenge to the Health and Care Partnership Board.
Okay, so what we're saying, so that leads us to a recommendation for the Health and Care Partnership, that they confirm that dementia is one of the areas that they intend to focus on. And I'd just like them to say yes or no to the Health and Wellbeing Board if it is. And that if they do, what does that mean in practice? And how will they engage more effectively with GPs? So that's a question to them that would be good to have a report back to the board on, whether or not Sue Rooston can somebody come and do that, because I think this is we are in such an interesting place in the borough, such a good place. I'll bring you back in, Meryl, but such a good place that I just want to drive this hard at this stage. And you've identified some really fundamental issues. Meryl, on diagnosis and GPs?
Well, it's on the Health and Care Partnership. One of the things that they might actually suggest is that the dementia is included in the frailty program, the frailty campaign. I'm not sure that that's a good idea. Jim and I actually are on the frailty group, which is looking at end of life and so on. I think it could get subsumed in a way that will lose some of the power it's got at the moment.
A very interesting point, Linda. Is the only way of adding dementia to health and care partnerships agenda by shoehorning it into one of the existing campaigns? Because you see, the campaigns, as much as I love the people involved in the health and care partnership and have a lot of time for it, and I like the way it was not developed, it was not discussed at the Health and Care Board for whether we want to agree with the campaigns. They were just presented to us, rather, I feel it was a bit presented to us, not properly discursive. And we've learnt a lot since they were first brought into being. So I think I would be happy, Linda, when you have your conversation, you would say it shouldn't be shoehorned into a campaign. I'm using the NHS word there. Okay, that's one helpful thing on diagnosis. The issue about, we lost Helen. Oh, Helen, hi, here you are. You've got your hand up. Wonderful. Do you think that you need more money from the CCG to increase your capacity to meet the national diagnostic standards that was suggested?
Yeah, I'm not sure about that. I think I would agree with Suhana in terms of the comment in some ways. And I think what I was going to say specifically, I mean, going back to the report, there is in there, Suhana's just setting up a group which is looking at diagnosis and all the complexities and the bits of the jigsaw puzzle that makes up that target. That's where we need the primary care representation. I did understand that there was agreement for primary care representation, although I don't have detail on that. So that's what I was going to say. The other thing I was going to say. Sorry.
Yes, sir, go on, please.
That I do feel that dementia is a priority, but I agree. How does it get named within the partnership in terms of it being a campaign? And I don't believe it should be subsumed into another campaign. Absolutely not.
I think where we're getting to, it's very helpful you raised that again. I think where we're getting to, and Linda will take that back, it needs to just stand alone. I think the campaign thing is so sort of I'm just going to talk because, one day I'm a councillor, the next minute I'm sitting from outside, but the campaign is such a leaden term to use anyway, and it's an typically incomprehensible NHS term, forgive me talking as a layman, that I don't think we should, I think it just has to be there and we have to focus on it. But Helen, what about the issue that the suggestion that you don't have enough capacity to meet the national diagnostic standards at the moment?
So I can probably come in on that, Helen, if it's helpful. So we're commissioned for the 9-week target. The national target is 6 weeks. So when we were commissioned, it was for 9 weeks. And so that's the target that we work to. So actually, if we were to be looking at the 6-week target, yes, we would need more funding for that. Absolutely. Okay.
And Toby, I don't know if you want to add anything at that point. You've got a hand up.
Yeah, I mean, it's just a statement of fact, as Suhan has just described it. Just a quick thing on GPs. There are some brilliant GPs in the patch who are incredibly passionate about dementia. The previous model under CCGs and federations was that colleagues like that had specific funding to be able to build time into their working weeks to be able to engage with this type of work. That seems to have diminished over time.
Funding from where? Funding from the CCG?
Yeah.
Okay, so the CCG still the CCG such as this still has the ability to make funding available.
So it's a question. As I say, there are some brilliant GPs. We'd love their kind of engagement with the group that Suhana's going to chair. The mechanism to do that, I wouldn't wish to speculate on, but whatever works.
Okay, so how can we? Well, let's talk about the mechanism for a second. If you've got brilliant GPs who are keen, and because this whole thing has worked so brilliantly, because of the enthusiasm of volunteers such as yourself, Toby, and Peggy, and people, and it works because people really care about this. So if we've got people who are gagging to do something, but there's an obstacle in their way, we ought to take that out of the way. Any suggestions, Mr. Diplomatic? Any suggestions from anyone else about getting more GPs? I mean, would we just? Linda, it seems to me that there's a whole discussion that needs to take place on dementia at the Health and Care Partnership. And I wonder whether we couldn't, now Toby, I may be overstretching, stepping over the mark here, whether you'd like to come and I'd like to come, because I haven't been to the Health and Care Partnership for a long time, whether we'd like to come and have a discussion about dementia, maybe with Peggy there at the Health and Care Partnership, to try and very specifically talk about what they can do to make things work better here in terms of diagnosis and resources and data. If we organise that.
Councillor Coleman, if I may, if I can take the whole conversation back, because I think as Toby was saying, we used to have GPs with specialist interests who were paid and they were released, they were backfilled to release them from their clinical time to do the work. So I guess the question is, how are we going to raise the profile of dementia at the Health and Care Partnership? Can we, as it is a separate campaign? And can we look at paying GPs with specialist interests to help us lead this work? I think we need to put those. I need to put those questions to the exec, and then perhaps we could set up a meeting with yourselves, as you said.
All right. Very happy for you to have the conversation. Very happy for you to have the conversation first. Thank you very much for that. I would like, Toby, if you don't mind coming, I would like it. I mean, I think you have amassed, all of you who've worked on this together, amassed such expertise, and also I sense, alongside the enthusiasm, I sense some frustration, and that's what we have to address as well.
These are all not uncommon problems. These are challenges that we're facing all over the NHS, and I think what we're trying to do is just be quite specific on what are the things that would really make the difference. So it's a short wish list.
Good. Okay. Well, let's let Linda. Why don't you have the first conversation, then Toby and I can come to the next. If you don't mind, Toby, you won't be doing other things by then. But if you still don't mind coming to the next Health and Care Partnership, because I don't want to lose. Well, none of us wants to lose any of what's been learned and the questions raised. And I think that I think we all recognise that these are systemic problems. They're not down to individual people not doing things. It's down to a system which has developed, which has created obstacles and barriers. Okay. Divya, would you like to come in?
Yes, absolutely. Thank you very much. I mean, some excellent points have been made in terms of raising visibility. But my question what I'd like to understand is, where does the problem lie? Is it the problem that people who have dementia aren't going to get diagnosed? Or is it the fact that we need better diagnostic pathways to make diagnosis easier? Where do we think the problem lies? And how do we get the answer to these questions? Perhaps through the GP route, which was suggested, but maybe if we understand it's a better awareness to destigmatize diagnosis of dementia by encouraging more people to go to get a diagnosis, or is it improving the diagnostic pathways, in which case it's the GPs that we need to work with, the primary care trusts?
It make me think, if we encourage people to get a domestic dementia diagnosis, is there going to be the resource there to provide that diagnosis?
Yeah, excellent.
So let's look at the thing in the two parts of the thing. So first of all, let's make sure that there is the resource to provide the diagnosis. So let's just check that that's going to be in place, and if it's not, why it's not, and what we can do to make it put it in place. And then the second thing is we can then think about a campaign which is about making people aware of the need and destigmatizing it. And the council can perhaps work using its comms people with the NHS, neither of which are necessarily the first place that people will turn to, but we could use places like Nextdoor and others just to raise the issue. And Peggy, I'm sure you and others will have ideas about how we can encourage people to get diagnosed. But let's make sure that if they do want to get diagnosed, that they can get diagnosed.
Yeah.
Brilliant. I'm going to move on from diagnosis to we've also, your second point about dementia competing for resources. I think that was a health and care partnership, and we talked about how we're going to take that forward. Let's talk about data for a minute. I am intrigued by Jim. Did you want to come in on data, or is it something else? If it's not data, I'll bring you in later. Is that right?
On diagnosis and data and GPs, because they're tied up.
Yeah.
And analytically, you can actually separate them, but in practice, you can't. I think if you go back to the previous conversation on inequalities, we were going to diminish things, less obesity, fewer heart attacks, that kind of thing. We know the national figures on this one, things are going to get worse. There's actually remarkably good national data. So it's a growing problem with a growing older population. So like it or not, GPs and the Mental Health Trust are going to have to put more resources in terms of time, but also I'd suggest for GPs and for data to train their entire staffs, because the first thing person one comes across is not a GP, it's the triage person on the desk. So there's a training function there for entire practices, and that's why Meryl's suggestion of having a GP representation here to say, as we've now nationally begun to reluctantly accept the numbers are growing, the numbers of people with severe dementia are growing, and we know roughly the figures is what are the new training routines to catch dementia early that all GPs and their full practices will do, so that on the desk to the GP, there's a clear route. And that means an information route, a training route, and a kind of taking responsibility, because it brings in other things we haven't time tonight to bring in carers, etc. But it's only recently, I think, we've begun to accept we don't know how to cure dementia at this point.
Okay. So going back to data, thank you, Jim, for that. And you do make me think actually about data. You make me think about GP representation at Health and Wellbeing Board. I think we should invite every PCN to send a representative. It may not be the clinical lead. It may be someone with passion, and it's not just going to be they're going to sit here and talk about stuff that doesn't interest them every day. But loads of what we talk about, GPs are absolutely core to it, and it's always as if GPs are a bit of a. We have to sort everything out first and then talk to GPs. So let's David and Linda, if you could talk about inviting all the PCNs to send a representative to this board. If they find it pointless, they won't come. But if they come along and they get engaged, I think that would be helpful to us.
Will do.
Thank you. Going back to data, why is it inaccessible? Where is the data held? I'm not sure. Toby, where's the data held?
So perhaps a couple of things to say on this topic. I think so. There is various bits of data held by different providers and commissioning organisations in and around Hammersmith and Fulham. And actually, in order to really understand what is happening for local residents we really need to join some of those different data sets up so that you have a complete picture. So diagnosis rates is a really good example of that, where there's some really useful data that sits with West London Trust, which we now, can see on a regular basis, which is fantastic. That's part of the issue. It's not the full picture. There's data that sits in the ICS that tells you about things like diagnostic rates and the diagnostic gap between expected and observed prevalence of dementia. There's data that sits in the primary care records. There's then data that actually sits at Imperial, who run some services that support especially people who are younger, who have a diagnosis of dementia. And it's only by stitching all these things together you get a complete picture. And that's actually quite a bit of work to do it properly. And I think what we know is that takes quite a bit of time, but also takes a degree of transparency to all of those organizations to make that data available. So that's part of the issue. The other thing is whole systems, which in theory is the kind of panacea here that helps to join all these different data sets together, including social care data. But it has been really quite difficult for us to help to build a data set from whole systems that we can use.
Why?
In part, I think they're just not doing it elsewhere in Northwest London, so they have to kind of run the extracts kind of from scratch. I'll be honest, it didn't need to take a year. So we now have data, which is incredibly important. And to be honest, any work that we do in the Health and Wellbeing Board and the Health and Care Partnership should be underpinned by these data sets, because then you know actually what you're doing is making impact.
Okay. So do we know? Sorry, do you want to add to that? I was going to ask another question. I keep asking you a question, but we know with the West London Trust diagnosis rates, we have ICS data. I'm never sure what ICS means these days. I mean, we have ICS data. There's somebody in Marylebone Road holding data. Okay. We have primary care records. We have Imperial NHS Healthcare Trust. You presume you mean them, or you mean Imperial College Healthcare Trust? Yeah. We have social care data. There's somebody in each of those organizations who is not that interested in that particular data and sharing it, or they would be doing that. So our challenge is to make them more interested in sharing it. Is it possible for, would it be helpful if, as the Health and Wellbeing Chair, I wrote to particular people asking them to come to a meeting to discuss this? What is the best way of doing it? We need to get people, we need to make it important enough to people, and I'm not sure. Toby, what do you think?
So my view as a kind of third party in this, and obviously I'm here in my role as an independent chair, is I think for anything that is a priority for the Health and Care Partnership or the Health and Wellbeing Board, there should be a specific set of data that's used to help track performance on that particular issue or campaign or whatever you want to call it over the course of a year. And that needs to go alongside qualitative data and feedback from local residents and all of the kind of soft intel that goes around it. But you do need a consistent way of doing that. And that capability exists, but it is not well utilized in Northwest London. So I think that would be my plea, I think, going forward.
Yes, I think I understand that. And I think that's an elegant way of restating what you said. And I'm not going to keep putting you on the spot to ask you to identify individuals, but I think we need somebody to drive this and lead this, and somebody needs to reach out to the ICS, the primary care, the Imperial, and social care. It seems to me this would be led normally, and I can be corrected on this, Sahana and Helen, by the West London Trust, would it not? Not necessarily. We need somebody to take on bashing everyone's heads together to get the data out. I mean, let's have suggestions. I said one thing. There's a sort of shaking of heads here. Peggy?
Lucy Smith at NWL.
Lucy Smith.
The person who did the commission for the diagnosis assessment.
Okay. So, Linda, can you set up a meeting for me with Lucy Smith at Northwest London ICS for me to talk about this challenge and see how she wants to help us resolve it?
Yeah.
Okay. Because I just know that there are fantastic people with fantastic things, but just you've all got priorities, and we need to make this a priority and help Lucy pull everyone together. And she finds it frustrating to get information out of somebody else, but she agrees to lead on it. Then we can help her with that as well. But let's have a conversation
She
with
does
Lucy
it
first.
for Hammersmith and Fulham, sir. She can do it for the other 7 boroughs.
Well, I'm delighted to help the other 7 boroughs, but I wanted to help Hammersmith and Fulham at this stage, and then we can show the other boroughs. We can show the other boroughs an example of what can be done when you do everything that is necessary. I'm not going to. I can't. Much as I want to help everyone in Hillingdon, Harrow, and Ealing, and I'm going to run through them, which I do. I want to make sure it's working here first, and also, as I say, if we get it right here, we can show other people. But we can't expect them to do everything for everywhere at once. So. If it's all working, but it doesn't seem to me it's not working for Hammersmith and Fulham, is it, Peggy? We've got all this data which isn't being pulled together. So we also need to we just need to understand. I'd like to understand that better and share this report with her maybe, and we can have this meeting, and she can, Joe, maybe you can come along as well, and we can make it work. Good. Nadia, you've had your hand up for an unconscionable length of time, and then Sahana, I'll bring you back in.
I have. Thank you so much. I was patiently waiting. Just a few words, really. I mean, the conversation has moved terribly far from where I actually wanted to step in, but nonetheless, I do have quite a few things to say, but I will be brief. Well, first of all, I'm incredibly proud of the engagement work and co-production work that our borough has been doing on in a number of areas, including dementia, and obviously this fantastic presentation we just heard is a testament to that. But just a comment on this, I really would like, I know we've moved on from diagnosis, but Healthwatch is doing a dementia dedicated project at the moment as well, and diagnosis is a huge problem. And I'm trying to understand what it is that that diagnosis entails, that it actually, the answer to everything isn't more funding. I know there is obviously capacity and there is, funds are always required, and funds are always, one likes to think, well used. But what does the diagnosis actually entail? And I'm trying to understand where the difficulties are coming from, and why the rates are so low in our borough. And that's the one thing. And the other thing I wanted to say is the wonderful engagement work and co-production work with a number of sort of strategic pieces of work that the council has been working on. But could I just, it's a request, it's not a criticism. It's become very clear to me that carers are actually not engaged with to the extent that they that other resident group have been. You've obviously mentioned carers were involved in the dementia project, but there is a dedicated carer strategy that the borough is doing. And from this is from a carers network perspective as well as Healthwatch's. There seems to be a problem of getting carers involved, because there is a restrictions to how many carers are involved in the project. The council is selecting one carer. A fortnight or so ago, there was a meeting where a ballot had to be drawn as to which carer can be selected to speak. And I think there are opportunities for very beneficial and useful feedback to be collected, which I think are being missed out on, unless it's very difficult to understand why engagement and co-production has been so excellent in so many areas, but not when it comes to actually working on the carers dedicated strategy. So diagnosis and the difficulties there, and whether carers can be more involved in the carer strategy. Thank you.
No, thank you, Nadia. And Sahana, if you don't mind waiting just one second, I think Joe wanted to come back specifically on that, because it's about how the strategy was developed. Joe?
Yeah. Hi, Nadia. Nice to hear your voice. Yeah, carers were very much involved in developing the strategy, and the carers network, and Paula Linhan was absolutely superb from the onset. And we've continued to work with the carers network since. I'm not quite sure what you're referring to in terms of people being nominated.
I think there's a slight misunderstanding here. I'm not talking about the dementia strategy. I know dementia or autism strategies. There's a lot of work going on for a carer specific strategy.
That's right. Yeah.
And that is where care engagement is lacking.
Right. Okay.
Meetings took place a fortnight ago, and as I say, a ballot had to be drawn and one carer selected. I can't understand. I'm not just kind of being the chair of Carers Network here, but I cannot understand why myself as a full-time carer, as well as chair of the organisation that is commissioned for caring services, was just absolutely barred from taking part.
Okay, Nadia, wait a minute, Nadia. Before I want to pick your point up. I don't want to lose this. I don't want to pursue it tonight, but I don't want to lose it. Joe, I don't know if it's you or Linda who's leading on the carer strategy.
I think we're both very much involved in the
Yeah,
care strategy.
okay.
I'd very much like to speak to Nadia, Councillor.
Would you speak to Nadia and,
Yes,
and
that's
understand?
okay.
I think it's
Yeah, of
important, Nadia.
course.
You're raising important issues here. We have to engage with as many people as possible. And you rightly have pointed to the excellent way in which it's happened with the dementia strategy. Same thing has to happen with the carer strategy. I was going to draw out again at the end of this meeting how it's a bit of a blueprint, the way we've done the dementia strategy in terms of co-production. And
it's been excellent, absolutely.
It's been excellent, and we have to apply this across the piece. So, Joe, if you could talk to Nadia, and then you and I could have a conversation, I'd appreciate that. Thank you very much, Nadia. It's a great point. I'm going to bring Sahana in now. Thank you.
Yeah, just very quickly. Diagnosis rate multifactorial and would take ages to talk about, and I think that's why it's so complex. So I just don't think it's about one thing. I guess what I wanted to do is end on a high, in that I sit in a West London ICP meeting with the other boroughs in West London, actually the dementia strategy and the work that has been done in Hammersmith and Fulham is mentioned frequently. Because it has stood alone. And I think that's a learning point in terms of going forward, and what you were saying about the campaigns. In the other boroughs, they are absorbed into things like frailty and they get lost. And I think this work has only been possible because it sits separately. So well done. I mean, I think in all the boroughs that I've been in.
No, that's a really helpful point. And I think it just shows, you can only do so much. You can only do so much within a structure that has been created partly from on high, and then a group of people get together in a room and they think this is the right way of doing things, and then suddenly it is the only way of doing things, and it's not how we should be. This has been driven by individual passion, and the amount of people that it's going to help is extraordinary. And if we can unlock some of the big problems that around diagnosis, I still think we could talk longer around diagnosis. I'd like it again if the Health and Care Partnership, Linda, as part of their work on this, and I think this is going to become an important part of the work, could identify the various problems around diagnosis, and then together we can think how we can crack those, along with the data issues. But you've achieved, coming back to you as a group, Toby, Peggy, Joe, others who've been involved, you've achieved an immense amount, I think, already for residents. I think you've given people a sense of hope and a sense of progress. But we are at the foothills of putting things right. The fact that we aren't great at it, we can pat ourselves on the back because the others are even worse. But that doesn't mean that we're where we want to be. We know that we're not, and that's part of why I like working with you all, because you're also not trying to take. So we've done great things. So, Meryl, do you need to come in before I finish?
And I'd just like to make one quick point, because it overlaps with other things. I have mentioned this to Joe and Peggy. One of the things that's missing in the priorities, and that may be because of who the people with dementia were that they were talking to in co-production, but is end-of-life care and possible nursing home, etc. care for patients with dementia. It's close to my heart because both my parents ended up with dementia.
Yeah.
But I think, particularly given that North West London ICS is looking at end-of-life care, it's really important that is something that this group looks at independently.
I hate to say it, Meryl, but whenever you put your hand up and I say, I must make another point, and you always make a really good point, and that's a really good point. And I was talking to a resident who visited somebody in one of our care homes at the weekend to deliver some flowers which had been ordered, and she was let into the home and she walked around the home, which in itself is quite odd, and she said there were just resident after resident sitting there who clearly had dementia, who were just calling things out to her, there was one nurse on each floor, and that was it. That was all there was to stimulate, to look after them for the weekend. So I think, yeah, and I can see people getting moved and annoyed by that. And I think there is a real issue about people living with dementia, and it could be end-of-life care. It could also be within our care homes, which is where people who are older often will be. So I think we need to look into that as well. Good, but we're in a better place than we were a year ago. and I have to say there are very few issues which we discuss at this board where people get so passionate, genuinely passionate, I suppose professionally passionate about, and this is one of them. And so again, I'm very grateful to you all for the work you've done. We have to take forward, I think the recommendation is that we both note we note the strategy, the report of the strategy, but we also determine to take forward the recommendations. And I'm trying to think how we frame looking at that. We have the most series of priorities, and there's actions on there, but we need to look at the actions there and can take them forward and make them further reported on. So I want to come back to dementia. We should come back in about 6 months to see how we've taken forward, particularly diagnosis, resources and data. But thank you all very much indeed for the work you've done. And Toby, I appreciate we'll meet in April with the GPs. And yeah, and a congratulations, thank you, as Sue says, we congratulate everyone involved in strategy on the progress made so far. A couple of other things. Just looking at the future work programme, I do think it's time to talk about GPs more. GPs are discussed a lot. They're brilliant. Some are brilliant, some are not, but they are absolutely essential to what's going on. And so often it's personal things which bring things home. But there is an issue about what treatment at weekends. The fact that GPs are shut at weekends, many of them are, many of them aren't. I think there are quite a number of issues that we want to talk about with GPs. Their opening hours is one thing I'd like to do. Well, we should have an issue on primary care about GPs. How would we frame that? What are the main issues that we think we should be looking at? We can't look at everything, and but we need to invite some GPs to come. We need to prioritise what we want to talk to them about. Meryl, you've got your hand up, then Linda.
Of course. It seems to me, and it's come up in a lot of groups and discussions I've been involved in, one of the big issues about GPs is access, about telephone, digital, etc., and who thereby is excluded from access or finds it very difficult.
Okay, thank you. Linda, and then Sue, and then Jim.
So I think there's something about how our GPs are managing with an increased demand.
Yes.
Generally, we've talked about health inequalities, but how are they managing that increased demand?
That's a very interesting one. Yes, Sue.
In terms of GP opening hours, I don't know if there's any correlation with hospital services that are only open Monday to Friday, because I think quite often people end up either in hospital because their GP is closed, or trying to go to a GP on a weekend because the person they want to speak to as a consultant at the hospital isn't available. I don't know if there's any information on what people are going to A&E for, or urgent care centres that could have been dealt with by a GP.
Okay. Thank you. And Jim?
I think one thing is impossible to miss, and that's the complexity of access on equality grounds in such a diverse borough. So
can you be a bit more specific about what you mean?
Yeah, we've got people who can't use digital very well, who can't afford digital, whose English isn't very confident, who need to get past the desk, and who give up. So I would like to know in practice about access between favoured areas in economic terms, the borough, and less well-off areas, because it came up at the previous meeting about diagnosis on mental health.
Okay, so whenever we raise things with GPs, the one thing I know is that they all feel very, very heavily overworked.
They are.
And that whenever you raise anything, it's another burden on top of all the burdens that already exist. And yet I know they also want to be. So when you talk about, I want you to come along and talk about becoming more accessible, and that's what 3 people have talked about. They think, oh God, I'm going to have to go to another bloody meeting, and I'm going to have to spend time. I could be, and it's how we actually can have a conversation with GPs, which is useful to them as well as to us. And perhaps if I understood more about the challenges around access, I'd be able to answer the question more readily. I think access is the big issue, but GPs do feel, as you, Linda, you're putting it in a polite way, how are they managing increased demand? They feel snowed under. How are we going to have a constructive conversation about access rather than saying, why aren't you open at weekends? You know, what do we pay all this money for? That's not really going to be. Why don't you do, you know, why is it so difficult on digital? I mean, how can we have a conversation with GPs which is fruitful and constructive, and what do we need to do to prepare the ground for that?
And can I just quickly come in again? I don't know how many active patient participation groups there are in Hammersmith and Fulham. What I do know is that my own practice doesn't have a very active patient participation group, despite pressure to get one. And I raise that for a very particular reason. This borough has been very good at developing co-production. And it seems to me that one of the things one could offer to GP practices and to PCNs, strategy for working with their patients to improve access in a way that meets the needs of patients, but also takes into account the needs of staff in the practice. I'm putting it superficially, but it's.
No, I understand that. I'm just thinking.
We've been trying to talk to our own practice about.
Yeah. We can all start. I'm tempted to start citing my practice, but I'm not going to. Because interestingly, the doctors themselves are so good, but the system that is in place isn't sufficient for the needs. So does I mean, Linda or Toby, you come back into view. I don't know if you want to add anything at this point. Bravely into view. It's about how we can start to have a conversation with GPs who are already feeling stressed, overworked, but yet we need to address this really important issue of access, because it isn't the same across the whole borough. Some places offer better access than others, so it's doable. Linda, I don't know if anyone would it be useful for me to come and have a conversation with the clinical leads? I don't know, would that be too difficult a thing to do? I'm aware of the need to tread carefully, and yet we have to address the issue.
I think Toby's got his hand up.
You have got it up, Toby. Good, please.
I couldn't resist. I'm sorry. I do need to jump off in a sec, but I just wanted to say, I think by the time the board meets next, there will almost certainly be some kind of national plan exactly on this topic. And that might be an interesting jumping off point for a conversation with colleagues locally about how you might go enacting some of the national ambitions around access to general practice.
That's very helpful indeed. That's a very helpful point, and we will have something on GPs at the next meeting, but we will frame it in looking at what happens nationally. Thank you, Toby. The last thing I want to say, if I may, is just just to mention Lisa Redfern. Lisa Redfern, who is one of the most amazing officers I've ever had the pleasure, I think many of you are nodding already, pleasure of meeting, is sadly decided to retire, which is an odd thing for somebody in their 20s to do, but there you are. She's going off, and I'm sorry she's not here. But she and I started the adult social care. Well, she didn't start in adult social care at the same time. We started in adult social care here in Hammersmith and Fulham at the same time. She had a lifetime of professional experience behind her on that, and I had to learn a lot from her. But she, for me, and I think for you, I'd like some words, if I might, from the committee, just to be recognised in the minutes. I think I found her to be professional at the highest level. I found her to be strategic and detailed, kind and caring and tough and brave and honest, and not somebody who plays games, and somebody who sets high standards and isn't afraid to hold people to high standards, and rebuilt social care to be what it is today. So I think it's and the fact that we have so many excellent people, who we've had the pleasure of working with, like Linda and Joe and others, is the team that she built up, is another tribute. If I can call you Linda and Joe, a tribute to Lisa, it's not too cheeky, is a tribute to her. So I would like to minute from the committee, if you agree with this, our thanks to Lisa. She couldn't be here today, she's not well, otherwise we'd have been able to do it to her in person. But this would have been her last Health and Wellbeing Board, and it's going to be, I'm going to be very sad when she goes, but I think we're all the better for what she's done for us. I just wanted to say that. Yeah, thank you very much. Okay, well, on that note then, thank you all so much for staying the course this evening. And there's lots of things for us to do. I'm looking forward to the minutes. David, I'm very happy, David, if you want to produce shorter, quicker minutes, that would be fine. But they don't have to be hugely detailed, but the main actions that we decided to take and things would be welcome. Is that all right?
Will do. Yes, Councillor.
Wonderful. Thank you all so much. I look forward to
Thank you,
seeing what
Ben.
you do.
Thank you, everyone.
Thank you all of you.
Bye.